want to move on to our next patient. George has severe dyspnea. And he states in the emergency department, I do not know this feeling. Doctors, I never go to doctors. I don't like doctors. But now I feel really bad and his O2 saturation is only 76%. Now we have to figure out what is the problem of George. Well, of course, we utilize echocardiography. And in this focused 4-chamber view, we have the right ventricle in the center of our image. So this is the right ventricle, the left ventricle, the right atrium and the left atrium. So a focused 4-chamber view where especially we focus on the right ventricle and also in this case on the right atrium. So here we added the information where we do see the right atrium is severely dilated. Compare the right atrium to the left atrium, it's definitely larger, even though it's not the optimal view for the left atrium. Then the left atrium and also the right ventricle is severely dilated compared to the left ventricle. And if we take a look at the interventricular septum, we do see this bouncing and shifting motion from the right towards the left. So this indicates that the right ventricle truly has a problem. In this case, when we look closely at the motion, it might be a pressure problem of the right ventricle. Why? Because also the free wall of the right ventricle, we do see parts of the free wall, it's definitely thickened. The left ventricle overall doesn't seem to be severely impaired in function or severely hypertrophied. So the primary cause in this patient is probably pulmonary hypertension. The diameter in this point of care setting was measured with 70 millimeters, the basal diameter, you would measure it over here, and the function is definitely reduced. So we have the combination of a dilatation of the right ventricle with a reduced function and probably a thickening of the right ventricular free wall. Of course, we want to have more than one view. Adding some more views, in this case we have the apical view where we see the right ventricular inflow, outflow view. This is a view where you rotate around the right ventricle in an apical position. This will also be discussed in the compact echo course when we talk about the apical views of the left and the right ventricle. And we do see that several parts of the right ventricular walls, they are definitely thickened and the function is definitely reduced. In this reversed 4-chamber view, we simply over-rotated, so the marker now not points laterally to the left side of the patient, but almost to the right side. And we do see again that the right atrium is severely dilated, the right ventricle as well. And we have this bouncing and shifting motion of the interventricular septum also forming. In this case, you can even see it a bit, the so-called D sign in this reversed 4-chamber view. Of course, we have to measure now and find the tricuspid valve and tricuspid regurgitation. And we already discussed that this might be a case of pulmonary hypertension. If we do take a look at the tricuspid regurgitant signal, we do see it's not optimal. So it's a relatively weak signal, but it's definitely exceeding 3 meters per second. So this is a case where we think pulmonary hypertension is present, and this might be the cause why the right ventricle is dilated, hypertrophied, and impaired in function. It is very important to also visualize, of course, tricuspid regurgitation, because if you have a massive or torrential tricuspid regurgitation, you also have a volume problem, so volume overload of the right ventricle. So it's very important to see and differentiate, is this a valvular heart problem or it is truly a pressure problem, as we assume in this case. Of course, adding lung ultrasound makes the picture even clearer. We have here parts of the lungs, so in the anterior field on the left side, here again on the left side with a linear transducer, and here on the right side, we do see that the lung surface, or the pleural line, is irregular. It appears thickened, and we have plenty of those so-called reverberation artifacts. In this case, comet tail artifacts arising from an irregular pleural line. We do see this with the linear transducer as well, that it's truly irregular. There are even some small consolidations, so these grayish areas and this irregular pleural line. In this case, on the right side, we have practically the same image. And this is the CT imaging of George. George has an idiopathic pulmonary fibrosis. This was an already established diagnosis. We didn't know the patient in our hospital, and the patient several times already declined therapy, ongoing therapy. Also in this case, he did not want a further treatment except oxygen therapy. Continuing with just a side note about tricuspid regurgitation. You have to measure tricuspid regurgitation where the signal is optimal. So you have here three variants. So at the left side, there is the over-rotated four-chamber view where we do see the dilated right ventricle and probably moderate tricuspid regurgitation. And we do see that the signal is definitely reaching now 4 meters per second. It's also a better signal compared to our point of care ultrasound we have seen. Still, the signal is somewhat incomplete. Moving on to the next image, you see a traditional focused four-chamber view on the right ventricle. We do see a fuller signal, quite a good signal, also reaching 4 meters or even above 4 meters per second, but still the angle is not optimal. If we look to the right side, we do see in this parasternal short axis view that we truly have the perfect angle. And when we place the measurement of the continuous wave Doppler there, we do see that we even reach almost 5 meters per second. So truly this is a severe case of pulmonary hypertension. So in case of tricuspid regurgitation overall with valvular pathologies, you have to find the optimal angle, and there it's very helpful to know several views where you can nicely see, in this case, tricuspid regurgitation. And then with the optimal angle, you can optimally measure it and quantify valvular pathologies.